Hi, my name is Nasreen ALFARIS. I'm an endocrinologist. I also specialize in obesity medicine, and I'll be giving the talk on pharmacotherapy for obesity today. These are my disclosures for this talk. And I'm going to start with what the available anti-obesity medication here. So here's a schematic showing all the available medications that we use for obesity. Either it is on label or off label. And we can see them here categorized to adrenergic, anti-epileptic, anti-diabetics, and others. And everything here in green is FDA approved for the use in obesity, and everything in red is what we use off-labelly. So you can see here phentermine to pyramate combination is FDA approved, phentermine on its own, bupropion, naltrexone combination, for the anti-diabetic agents, we have the liraglutide 3.0, semaglutide 2.4, and tirzepatide in all its doses from 2.5 to 15 milligrams. And then we have orlistat, and then we have Gelesis. And Gelesis is most so not really a pharmacotherapy, probably a device, I would call it. But these are the things that are FDA approved. If you look at the off-label use, we do use bupropion on its own. We use naltrexone on its own as well. We use topiramate on its own, zanisamide. We use all GLP-1 receptor agonists as well, metformin, all SGLT2 inhibitors, and pramlintide in the management of obesity. So if you were to see where these medication works, so most likely when we look at obesity and when we look where medication work, I really like to focus on the neuropeptide Y Gouty-related protein pathway and the POMC CART pathway. And if I want you to think about them, I want you to think about the POMC CART pathway as the pathway that tells you not to eat, and the neuropeptide Y Gouty-related pathway as the pathway that tells you to eat. So here you can see, for instance, that bupropion, naltrexone, liraglutide, semaglutide, all these GLP-1 agonists as well will work on the POMC CART pathway, the not to eat, and decrease food intake. You can also see in the higher neurons, such as GABA neurons, you can see topiramate working there. You can as well see that these GLP-1 receptor agonists not only works on this, lower neuron eat and not eat pathways, but they go even higher, working on the GABA neurons, working on the VTA, and working on the nucleus accumbens as well, all working in all areas of the brain. And that's where the disease is, to basically have us treat obesity. When we look at peripherally, we do know that liraglutide and semaglutide and probably even tirzepatide all have some peripheral action. But really, as I said, mostly their action is centrally on the brain, causing weight loss. The only drugs that we think about as peripherally, and that's why we don't really like to use them, because they really don't work on the actual disease of obesity, are orlistats and its group. And those are this is a lipase inhibitor, and because it is basically what happens, individuals who take this drug they only just don't absorb the fats from the intestines, and they end up having the side effects that are associated with that, and probably some weight loss. And I'll talk in detail about the weight losses that are associated with the different anti-obesity medications that we have. So if you look at orlistat, one of the oldest drugs that we know and something that everybody feels comfortable with using, primary care physicians, endocrinologists, internists. As I said, it is a pancreatic lipase inhibitor. And if you see over 208 weeks, the total body weight loss was really, really minimal, about 5% at the most of total body weight loss in drugs like orlistat. If you look at things like phentermine topiramate combination, this is the most effective anti-obesity medication taken orally as of now. And this is brand name Kisimia. And you can see here, as compared to placebo, at 2 years, on the highest dose, phentermine and topiramate will cause about 9 to 10% of total body weight loss. So of all the oral preparation that we currently have now in the market, this is the most effective oral preparation that we have. If you look at bupropion naltrexone combination, you can see at 56 weeks about an 8 placebo subtracted about the 7% of total body weight loss with bupropion naltrexone combination, brand name Contrave. And you can see here when you look at categorical weight losses, so meaning how many patients have lost 5% or more of their weight, how many have lost 10% of more of their weight, and how many patients have lost 15% of more of their weight. You'll see about a little bit more than almost 2/3 of patients will lose 5% or more of their weight, and then about 39% will lose about 10%, and only about 18% or 19% will end up losing that 15% in the randomized control trial. Liraglutide 3.0 was a miracle drug when it came out. It was the first GLP-1 receptor agonist FDA approved for the use for obesity. And as I said, because these GLP-1 receptor agonists not only work peripherally, but they really have very good central work where they work on different areas of the brain centrally, they tend to cause more weight losses. And I'll talk again more about why is it important to work on more areas of the brain later on when we talk about other drugs. So you can see here at 160 week, it's about 6 to 8% of total body weight loss with liraglutide 3.0, with about 50% of patients taking it losing more than 5% of their total body weight loss, which is clinically meaningful weight loss. You'll find about a fourth of the patients will lose about 10%, and then about only 11% will lose about 15%. So when it came out, it was great. It was a proof of concept drug for GLP receptor agonists. We have down the line, we learned that we have more effective drugs. And then comes semaglutide 2.4 milligram. Semaglutide 2.4 milligram is another GLP-1 receptor agonist. It's given once weekly. And the trials that we're looking at studying semaglutide 2.4 are the STEP trials. And you can see here with the step 1 trial, looking at individuals with obesity, BMI of 30 and above, or BMI of 27 and above, with complications of obesity other than diabetes. So in the step 1, they did not include patients with diabetes. You can see that the total body weight loss placebo subtracted have gone up to 15%. So this is the average weight loss with semaglutide 2.4. So we've moved from that proof of concept to actual very effective weight loss medications that we have with these GLP-1 receptor agonists. You can see this going across the studies with the step 3 being with intensive behavioral treatment. There's really no difference. So the drug is so powerful that even when you combine it with intensive behavioral treatment, you don't get that much of a difference because, again, biology drives behavior. It is not the other way around. So when you have good drugs, behaviors will change. Step 4, again, sustained weight management. Individuals were able to sustain their weight who were on the drug, and those who stopped the drug ended up gaining weight, which makes a lot of sense because obesity is a chronic disease and it has to be treated chronically. Just like hypertension and type 2 diabetes, we cannot stop anti-obesity medication, at least for the foreseeable future. The step 2 trial, the one looking at individuals with obesity in addition to type 2 diabetes, ended up losing less weight, about 10.6% of total body weight loss. The reason being that when you have type 2 diabetes in the mix, people tend to lose less weight, whatever intervention you have, either it's pharmacological or lifestyle or even surgical interventions. These are the categorical weight losses, what we were seeing there at 50% with liraglutide. Here you're seeing about 88.7% are losing that 5% of total body weight loss. 10% about 79%, 15% about 63%, and even 20% about 40% of patients who are losing this much of weight. Again, this is just comparing liraglutide to semaglutide. Here in blue is the semaglutide. In yellow is the liraglutide, and you can see the clear differences between the efficacy of the drug, the semaglutide 2.4 milligram, brand name Wegovy. Now, I was talking about these drugs hitting multiple areas of the brain, which is very interesting. And when they looked at semaglutide and cravings, they found that semaglutide also affects cravings in a very, very positive way, where individuals who are cravers actually tended to the drug tend to take away their cravings and help them even more with losing the weight. So taking semaglutide 2.4 milligram, when looking at different questionnaires, looking at different craving, really resulted in less craving in those individuals. Now, tirzepatide, which is a novel drug, this is not only a GLP-1 receptor agonist, but this is a one molecule that is a GLP-1 GIP receptor agonist. It is a more powerful form of these drugs. And what we can see here with the different doses that the weight losses go up to about 20% at 72 weeks. So we have really, really very, very powerful drugs that are very, very similar now, coming very close to what metabolic surgery causes with weight loss. Here you can see the categorical weight losses, what we were talking about in liraglutide, about 50% losing 50%, 5% of their weight. Here you can see that about 91% will lose that 5% of weight. And then as you go with the different categories, the more than 10%, the more than 15%, the more than even 20%, you're seeing that about 57% of patients are losing more than 20% of their total body weight loss. And because this drug is so powerful, they have even added a new category of even more than 25% of total body weight loss. And we can see here that about 36% of patients will be able to achieve those weight losses. When you look at different, and this is just, I'm just pointing out to setmelanotide, because setmelanotide is a drug that actually it's an MC4 receptor antagonist. It really targets a certain genetic defect that individuals have. So this drug has been FDA approved for those individuals with MC4 mutations, with PCSK1 mutations, Bardet-Biedl syndrome, among others. And what you can see here, these are patients that were started on the drug. And once they start on the drug, if they have the defect, if you have the genetic defect, they end up losing up to 3 to 4 kilograms per week. So once you know where the defect is in obesity and you target it, you get very effective weight loss. Now I'm going to shift to those off-label use of medication because I've talked about everything now that is FDA approved. And this is just a study looking at canagliflozin, an SGLT2 receptor agonist, looking at it, comparing it to placebo, about a 4.4% of total body weight loss in those individuals who were on the drug. And when you look at even metformin, when they categorized metformin in the diabetes prevention program as people who are responders and people who are not responders to metformin, they found that those people who are those individuals who are responders to metformin, weight losses went down to about 9% of total body weight loss when they were people who are responders, and they basically defined responders as those individuals who are able to lose more than 5% of total body weight loss at 1 year of using metformin. Again, metformin is a very, very good drug. It's been studied in randomized controlled trials for antipsychotic induced weight gain. And here, this is an older randomized controlled trial that looked at those with on atypical antipsychotics, olanzapine, and when they were started on metformin, on its own, they were able to lose about 5% of total body weight loss. When that was grouped with lifestyle intervention, they were able to lose about 7%. But those individuals who were in placebo that were started on these atypical antipsychotics actually gained weight, which we see a lot. So when you have patients that are on atypical antipsychotics, it makes a lot of sense to start metformin on those patients because it will mitigate the weight gain that happens with those individuals and may even cause weight loss in those individuals. Bupropion on its own, this is not Contrave, this is not the brand name. Bupropion on its own at 400 milligrams caused about an 8% of total body weight loss at the most. And so that, as I said, is bupropion on its own, not in combination with naltrexone. Topiramate, again, on its own, not in combination with phentermine, not Kissimmee, phentermine, topiramate combination. That caused about 9.7 percent of total body weight loss at its highest dose of 256. The only issue with topiramate is that it's a messy drug. So the patients may come off of the drug because of adverse effect. So it's really worth trying to titrate the dose up to see how much your patients can tolerate. And it's really important to think about these off-label use of medications because not everybody has access to care to these expensive newer medications, and we can actually achieve weight losses with cheaper options. Again, medications on its own are, monotherapy is very good, but combination therapy always does better. And we know that from, the hypertension literature. We know that from the type 2 diabetes literature. We do not have our patients on one anti-diabetic or on one anti-hypertensive. We usually use combination. And it's the same thing with anti-obesity drugs. The more you combine, the better results you get. So here you can see this is a study looking at canagliflozin on its own, phentermine on its own, and the combination cana-phentermine. And you can see that there's a synergistic effect when you combine an SGLT2 with phentermine, and you get about an 8% of total body weight loss. Again, if you combine phentermine and topiramate, not the brand name, just this is the EQUATE trial looking at generic phentermine, generic topiramate, and you can see that combination therapy yielded more weight losses than monotherapy at about 11% of total body weight loss. So this is just a graph that shows you all the FDA approved drugs and how much weight loss that you're going to lose. And it also shows it compared to lifestyle intervention and metabolic surgery. And you can see, as I said, as of this day, the most effective oral therapy is phentermine topiramate, which is going a little bit more than 10%. In the EQUIP trial. And then you can see, the different other drugs, the naltrexone, bupropion, brand name Contrave, and then the liraglutide 3 milligram, brand name Saxenda, and then the semaglutide 2.4 brand name Wegovy, and the different steps causing about 15% of total body weight loss. And then you can see here at the very end, the tirzepatide and the SURMOUNT trials, which are the trials that we're looking at obesity, not the trials that are looking at type 2 diabetes. You can see that it's touching about 25% total body weight loss. This is another comparison that we published recently in our paper in the Lancet, looking at the different drugs and comparing the three most powerful that we know: the semaglutide 2.4 here in purple, the tirzepatide in the yellow, gray, and orange, and then the retatrutide in all the other colors. And I'll talk more about retatrutide. Retatrutide is a triple agonist, and you can see here how effective these medications are as categorical weight losses go, more than 5%, more than 10%, more than 15%, and more than 20%. And you can see obviously that the retatrutide is the most effective drug that we have, but I'll show you the details a little bit further. The question is, I'm showing you all these percentages, but is it all about weight loss percentage? And honestly, the answer is no. So when you choose, when you're there, you have your patients with you in the office and you want to choose anti-obesity medication, always think about the patient as a whole. So if your patient has type 2 diabetes, has impaired glucose tolerance, has impaired fasting glucose, or even PCOS, the choices of a GLP-1 agonist and SGLT2 inhibitor or metformin are really, really good. If your patient is on atypical antipsychotics, then probably metformin is a better choice. If your patient has depression or is you want them to quit smoking, then bupropion is probably a better choice. If your patient has binge eating disorder, then topiramate or lisdexamfetamine, which is Vyvanse, is probably a better choice because these have been studied specifically in binge eating disorder. If your patient complains of migraines or then topiramate is a better or seizures, then topiramate, zonisamide are better options. So it's really important to think about your patient as a whole when choosing medications for weight loss, rather than just thinking about, oh, how much percentage will the patient get to lose. So move away from number of kilograms of percent of total body weight loss into making your patient healthier and benefits beyond weight loss. And to highlight the important things and benefit beyond weight loss, I think one of the hallmark studies that we have is the SELECT trial. The SELECT trial, we're looking at cardiovascular benefits of semaglutide 2.4 milligram in the absence of type 2 diabetes. So we know that GLP-1 receptor agonist has great cardiovascular secondary prevention in those individuals with type 2 diabetes. The question here, what is its effect in those individuals that do not have type 2 diabetes? Does it still have a cardiac benefit? So this was a study that looked at more than 18,000 patients with established cardiovascular disease. So it was a secondary prevention trial. They looked at previous strokes. They looked at myocardial infarction, peripheral artery disease, over 41 countries. They looked at BMIs of 27 and above, and again, no type 2 diabetes. And their primary endpoint was composite of death from cardiovascular causes or non-fatal MI or non-fatal stroke. And here are the weight losses in the SELECT. It is important to note that the SELECT is very different than all other trials for anti-obesity medication, and where there's a lot of males in this study as opposed to females. Usually anti-obesity trials have more females than males, probably because of the heart disease. They were looking at individuals with heart disease, and the age group was a little bit higher. You had a lot of people in their 60s, although they did have people in their 40s. And here the total body weight loss was about 9 to 10% at throughout the study at 221 weeks. And what you can see here are the categorical weight losses. So the people lost more than 5%, about 67% of people lost that. A little less than a half lost more than 10. And then the rest of the categorical weight losses were less of patients losing greater weight losses. But even with these lesser weight losses, you can see here that death from cardiovascular causes and heart failure composite endpoints and death from any cause were semaglutide. Those individuals on semaglutide 2.4 did better, fared better. And when you actually look at how much they did better, there was a decrease, 20% decrease in cardiovascular risk in those on semaglutide 2.4 as compared to placebo. So we know now that there is benefits beyond weight loss in those individuals with established cardiovascular disease, and in the absence of type 2 diabetes with obesity with semaglutide 2.4 milligrams. So it makes more sense to choose something like this drug in that population of patients. So what are the drugs on the horizon? So we have, again, as I said previously, when you combine drugs, you get better results. So this is cagrilintide, semaglutide combination. And this shows about, and this is the CAGR about 15.6% only at 32 weeks. So, and the graph continues to go down. So patients are losing more weight as they go. So we're expecting, greater weight losses as compared to semaglutide on its own and cagrilintide on its own. So again, combination therapy yields synergy in this drug. Oral semaglutide, this is not Ribellis's 3, 7, and 14 milligram. No, this is 50 milligram dose of semaglutide. This is a different drug, as of yet, not yet FDA approved, causing about 15% of total body weight loss when taken orally. It's really important to put in mind these peptide-based drugs that are taken orally. If you have patients that have metabolic surgery, you can't use them because they're just not going to work. Because they need that, because the stomach anatomy has changed, and basically the acidity of the stomach has changed, so they're really not going to work that well. Oral orforglipron, another GLP-1 receptor agonist, very different than oral semaglutide because it's non-peptide based. So you can take it without food. You can take it with food, sorry, and as compared to semaglutide, you can take it any time of the day. Really, you don't have to worry about this drug because it's non-peptide based. And again, very similar weight losses to oral semaglutide at about 15% of total body weight loss. Retatrutide, I showed you a slide previously on retatrutide. We're expecting this so far to be the most powerful anti-obesity medication that we have. Again, a once weekly novel drug. It's a GLP-1 GIP glucagon agonist. And what you can see here, this is the first time we see it. These are the phase 2 trials. 100% of individuals on the higher doses lost 5% of weight. We've never seen 100% in anything. More than 10%, about 93%. And then more than 15%, about 83% of individuals. And then we get the more than 20, more than 25. And now they've added a new category again, the more than 30%, and about 26% of your patients will lose more than 30%. So this is a drug that we're saying is very, very similar in weight losses, at least to metabolic surgery, because we're getting more than 30% of total body weight loss with it. Survodutide, again, a novel drug, a GLP-1 receptor glucagon agonist. Because of that glucagon effect, we know that this drug is going to probably be approved as well for NASH. And you can see here about 15% of total body weight loss. The graph continues to go down at 46 weeks. Another good drug. And here you can see all the categorical weight losses. Again, at more than 20%, about 32.8% of individuals will lose more than 20%. And again, remember, those drugs with the glucagon component will have NASH benefits as well, and will go for probable approval for treatment of NASH. Maritide, these are earlier studies on Maritide, but it's a very, very interesting drug. It's a GLP-1 agonist, a GIP antagonist, so not like tirzepatide, not a GIP agonist, it's an antagonist. What's very, very special about this drug as well, it's not once weekly, but once monthly. So it has a very long legacy effect. And you can see here about, again, 15% at 210 days. And we're really looking forward to see the effect of this drug and what this drug brings, because we're really very optimistic about these longer durations where we have a longer legacy effect, and probably we can space out these drugs even longer and longer and longer. Bimagrumab, a very interesting concept. Although the weight losses with bimagrumab were only about 6% of total body weight loss, but what was interesting with these activin 2 receptor antagonists is that with all the other anti-obesity drugs, the Achilles heel of those was the fact that individuals were not only losing the fat mass, but were also losing the lean muscle mass. Now, the thing with bimagrumab that is very, very good and very special is that it increases the lean body mass. So yes, you get not as much total body weight loss, but you get an increase in fat mass. So you tend to think about it. What are they going to do with the drug? Probably combine it with those very powerful GLP-1 agonists to try to offset that lean muscle mass that is going to be lost with those drugs. And probably we're going to get healthier patients losing weight rather than losing their lean mass. This is just a schematic to think about, again, from our latest publication, to think about how to use these drugs. And it shows, and it's really more of personalization. It's a very busy slide, but it shows how to personalize using these drugs. So if you have someone with obesity, you have to think if they have NASH, if they have pre-existing cardiovascular disease, type 2 diabetes, do they have obstructive sleep apnea? And then you start working down the line with that. If you have obstructive sleep apnea, we know, for instance, that tirzepatide has been studied in those individuals. So tirzepatide is a good option for them. Type 2 diabetes, then we think about nephropathy. If they have nephropathy, we know that there's the FLOW trial. So we know that probably semaglutide is a very, very good choice. If they have NASH, for instance, we think about things like pemvidutide, survodutide, those drugs that actually do have that glucagon component. And, and there's a bunch of drugs. Everything in green here is really anticipated for future approval, but not approved as of yet. So, what you can see here is that we have a bunch of really a very, very bright future for obesity medicine and really for personalizing treatment for our patients. So how do they all compare to metabolic surgery? I gave you a little bit of a hint. This is a borrowed slide from the amazing surgeon Ricardo Cohen, and he looked at retatrutide triple agonist and compared it to Roux-en-Y gastric bypass. And you can see Roux-en-Y gastric bypass here in orange, and then the highest dose of retatrutide here in dark blue. And you can see how close they are. So it's really, really getting close. So, and these are just from two of his trials, just just a prediction of what's going to happen in the future, not a head-to-head trial. How about post-metabolic surgery? I'll end with that because there's a lot of questions usually about that. Do we have data? Yes, we do. We know that pharmacotherapy post-metabolic surgery will induce further weight losses in people who are partial responders or suboptimal responders. We know that from the very optimized trials and with liraglutide, and we also know that those individuals will lose more weight once you start them on GLP-1, for instance, receptor agonist. Post-op, our study we published in 2013, where it was a multi-center study. We had individuals on different medication, either on label and off label, and individuals lost on average about 12% of total body weight loss when anti-obesity medications were added. The Gravitas study is a very interesting study. This was the only randomized control study looking at the use of anti-obesity medication post-bariatric surgery, but it's really important to note that that was not their primary endpoint. They were looking at type 2 diabetes, and the study was not really, powered to pick this as the primary endpoint. But you can see here with liraglutide, 1.8 individuals were able to lose more weight than those with placebo post-bariatric surgery. So really, the use of pharmacotherapy augmented surgical weight loss when used. These are the categorical weight losses, as you can see throughout these are the weight losses throughout time. And you can see as time went by, those individuals on the liraglutide tended to lose more weight. Again, it's really important to point out this was 1.8, not the 3 milligram, because this was a type 2 diabetes study, the Gravitas. Liraglutide versus semaglutide. Jamie Almondo's and his group looked at this, and they found out that if you were to use semaglutide, and again, this is not the 2.4 milligram, this is the 1 milligram semaglutide, as compared to the 3 milligram liraglutide, patients did better, fared really better with semaglutide as opposed to liraglutide post-operatively and lost more weight. More patients lost more than 5%, more than 10%, or more than 15%. So when we think about obesity treatment strategy, this is what is usually thought about treatment, and this is really what I'm going to end with. It's like a stepwise approach, but I want you to abandon that thought process. It is really not a stepwise approach. It is really more of personalization. to your own patients and to every individual patient. So what we tend to use is we tend to do the microenvironmental targeted therapy, or what's called lifestyle. We add pharmacotherapy. Sometimes we have to add endoscopic interventions. Sometimes we have to add metabolic surgery. Sometimes we have to do post-surgical combination therapy where we have everything on board for those patients. But it's really important to understand that your patient is in the center of this. And what you want to do is you want to give them all the tools to get them to a better place, rather than just using one, and then if that fails, move to the other, and then if that fails, that's really not the way we should use it. So my take-home points today would be really that anti-obesity medications are a very effective tool for treating obesity. But we should not only look at weight loss percentage with these anti-obesity medication. We should look at health benefits beyond only weight loss percentages. And we should try to give our patient whatever they can afford and whatever they have access to. Not, all patients have to be on, especially at this time where there's really difficulty in insurance for our patients and getting these anti-obesity medication covered by insurance. Then we can always use the off-label use of medications that are effective in treatment and that have already been studied in the treatment of these individuals, and just try to get our patients with obesity to a healthier place. Thank you so much, and I will end my talk here.